Chapter 17 is going to conclude the newborn care and congenital defects unit. When we start looking at Chapter 17, we're going to talk about the nursing care of the newborn at risk. The first three chapters have involved full-term newborns that have delivered, have appropriately transitioned, and are feeding appropriate according to their size and their caloric needs. Now, when we look at newborns that are born that are not appropriate, maybe they're preterm, maybe the risk factors were in the mother diabetes or hypertension, maybe there was a placental abnormality or interruption, maybe this mother has the presence of HIV. Maybe this mother has substance abuse addiction or another unhealthy lifestyle that has contributed to putting this newborn at risk. So when a patient comes in labor and is evident that a baby is going to be delivered, we need to review the pregnancy and health care of the woman. We need to look at the detailed prenatal history that hopefully will be provided by the provider's office. We need to plan and have a plan in place and an action that can hopefully prevent a newborn that is high risk from having long-term complications. For example, if we know a patient is coming in that has had gestational hypertension and is now pre-eclamptic, we want to be prepared that when this newborn is delivered, that we have respiratory personnel in place if there's an indication that there might be a respiratory situation or compromise when the newborn is born. So even though we don't know how the newborn is going to present when it's born, we want to have a plan in place and protocols in place and be able to put that in action as soon as the newborn is received. So this chapter is going to focus on some of those risks and some of these newborns that are delivered with these risks and what is our nursing interventions for these newborns. So let's look at a preterm infant. Now we know the gestational age to be considered preterm is less than 37 weeks. So anytime a baby is born with a gestational age of 36.6 weeks or less, it is considered a preterm infant. Now there are different characteristics. There is different appearances, not only physical characteristics, but organ characteristics and signs and symptoms that this preterm is going to exhibit. A preterm infant may have skin transparent or loose. You can see the veins, they're superficial on the abdomen and scalp. They don't have that subcutaneous fat, and remember, they probably are absent with the brown fat. They still will have lanugo, which is the fine hair. The vernix covers the baby. We talked about that. The extremities may appear short. The soles of the feet have few creases. We didn't talk about it in the latter chapters, but the more creases the baby has on their feet, it is a sign of maturity. So preterm infants will have less creases on their feet. Their abdomen may seem protruding or bigger. The nails are short. The genitalia is small and appears to be immature. And then in the female, the labia majora may be open. The labia majora is not closed. You can see the minora, and sometimes you may even be able to visualize the meatus and the clitoris on a preterm baby. So when you have a preterm infant and you look at socioeconomic status, maybe the mother was a habitual cigarette smoker. Maybe there's a history of premature births. Maybe there is a history of spontaneous abortions, therapeutic or spontaneous. Maybe there was little or no prenatal care. Nutrition might have been poor. There might have been infections that were untreated. We talked about preeclampsia or gestational hypertension. It could be a multiple gestation that caused preterm birth, and it could be placenta previa. So there are several risk factors that can go along with the characteristics of a preterm infant. Now, when you look in your book at a preterm infant, you're going to find more about preterm infants. Let me look and see if I can find the page. Page 293 and 294 and 295, a little bit in your book, talks about the preterm newborn. We talked about determining the gestational age, and these are some of the characteristics. We will use a Ballard score to determine the gestational age, and it determines different components of what the baby's prematurity is. And there should be a picture in your book of the Ballard score. I think it might have been in one of the previous chapters. So you can look back and see the Ballard score. So the muscle tone is less on preterm infants. And usually a preterm baby does not lie in the fetal position until they've reached about 35 weeks. So when you are expecting a preterm baby, you definitely want to establish the gestational age if you can, if the patient has had prenatal care, because you want to make sure you have your respiratory person in place. You want to prevent this preterm infant from having hypothermia and intraventricular hemorrhage of the brain, dependent on how premature the baby is. Several things with a preterm infant can occur. Apnea in the preterm infant can occur. Apnea is defined as the cessation of breathing for 20 seconds or longer. It is found to be common in the newborn, premature. It's related to the immaturity of the nervous system. Usually, if the preterm infant experiences apnea, they also experience bradycardia and cyanosis. So our nursing actions would be, if we are observing this infant and it has an episode of apnea, we would gently rub the infant's feet and back. We might suction the mouth and nose. We might raise the infant's head to a semi-Fowler's position. Usually it helps facilitate the breathing. Now, we can, by gently rubbing the feet, ankles, and back, it stimulates that baby to breathe. If we suction the nose and mouth, it's kind of an irritant, and it opens the airways and encourages that baby to breathe. If we are not able to stimulate the infant and respirations do not resume, then we may have to provide some positive pressure ventilation. We may have to do the ambu bag if other things do not work. Some hospitals incorporate using an apnea monitor for these neonates. They will order an apnea monitor. They may have continuous monitoring while in the hospital, and then once they go home, They may need an apnea monitor so that if they have an apnea episode at home, parents will be alerted by the alarming of the device that the preterm infant is wearing. Sometimes what causes respiratory distress is the immature respiratory system lacks the surfactant to keep the alveoli open. Okay, so what about if we have preterm bradycardia? It's less than 100 beats per minute, as preterm tachypnea is less than how many breaths per minute? Greater than equal to 60 breaths per minute, less than 60 breaths per minute, greater than 30 breaths per minute but less than 60, or less than 50 breaths per minute. So the analogy is preterm bradycardia is less than 100 beats per minute, and preterm tachypnea is what? Now Brady is less than 100, so tachypnea would be greater than what? So it's greater than or equal to 60 breaths a minute. What about birth asphyxia? Now, birth asphyxia is known as perinatal asphyxia or hypoxic ischemic encephalopathy. Now, what are the causes of birth asphyxia? The mother does not get enough oxygen during labor. These are some of the possible causes. Or the mother's blood pressure is too high or too low during labor. The placenta may separate from the uterus too quickly, resulting in loss of oxygen. The umbilical cord can be wrapped too tight around the neck or the body, which impedes on oxygenation. The fetus may be anemic and does not have enough blood supply or enough red blood cells to tolerate labor contractions. The newborn's airway may become blocked. The delivery may be too long or too difficult. So what is the pathophysiology of birth asphyxia? Asphyxia slows or ceases the breathing. It causes lack of perfusion of the blood to the brain and other vital organs. Hypoxia, which is insufficient oxygen reaching the cells, it forces the cells to undergo anaerobic respiration. Lactic acid forms and tissues become damaged. Then the lack of oxygen affects the brains, the muscles, the heart first. And when the heart dysfunctions, it causes hypotension. Now, when adequate blood perfusion returns, it can cause swelling of the brain, which therefore causes neurological problems. So it's a lot involved when you look at birth asphyxia. Now, we can only see birth asphyxia by the fetal heart rate. If the fetus is having decelerations, remember, think back to labor when the mother's having contractions, and late decelerations indicates a decrease in oxygen supply or placenta oxygen insufficiency, which causes, remember, the squeezing of the baby. They're going to not have some respirations because of the mechanism of labor, but if it's delayed, then asphyxia can occur if oxygen does not reach that baby. So hypoxic ischemic encephalopathy. Now, it can be defined as an acute brain injury caused by asphyxia when the baby did not get enough oxygen during the birth process. Some of your signs and symptoms are cyanosis, difficulty breathing, they may have gasping respirations, umbilical cord pH is less than 7, and they may have a poor APGAR score for more than 5 minutes. So these babies need immediate intervention and immediate care. They're going to go to the NICU, and they're going to need resuscitation, and they may need an airway device, and they may need ventilation to help get these babies stabilized. And you can look on the table 17.1 at the bottom of page 283 in your book, and you can see the medical management, the nursing care, and the long-term complications with infants that have hypoxia. If babies are born with inadequate respiratory function, it can be related to prematurity. During the second half of the pregnancy, structural changes occur in the fetal lungs. The alveoli sacs enlarge, and they're closer to the capillaries in the lungs. So if a baby's born prematurely, the muscles that move the chest are not fully developed. Remember, we said the baby may have a protruding abdomen, and that increases pressure on the diaphragm. And also, the respiratory center in the brain can be immature. The gag and cough reflexes are weak due to immature nerve supply. So we need to watch these premature babies closely for inadequate respiratory function. Now, pre-viability is before the baby is considered viable, and we know that's 20 weeks. There is failure of fetal lung development with the alveoli, the air sacs, and so that's why they have established an age for viability. 20 weeks or more is viability. Before 20 weeks, this alveoli and these capillaries have not developed yet. RDS, or respiratory distress syndrome type 1. It can also be called the hyaline membrane disease. Preterm infants are at risk for respiratory distress due to the deficiency of the surfactant. Remember, we said that the surfactant starts at 24 weeks gestation, and by 34 weeks, if the fetus is delivered, it should be able to breathe adequately. But that danger zone is between 24 and 34 weeks. If the infant is premature, the surfactant level could be present, but it may be insufficient. And remember, your surfactant is your fatty protein that's high in lethogen. Its presence is necessary for the lungs to absorb the oxygen. Now, the result of immature lungs leads to decreased gas exchange. And 30% of all neonatal deaths result from RDS or complications from RDS. Surfactant can be altered if the baby experiences cold stress, hypoxia, poor tissue perfusion. That can be some of the factors that causes surfactant to be altered. It can take up to several hours after birth to be manifested. Your baby may transition initially okay, but it may be later on. If cold stress occurs, hypoglycemia occurs, the surfactant is not like it needs to be, and the baby begins to struggle to have sufficient respirations. They start working harder to breathe, and so they might experience tachypnea. Tachypnea is usually accompanied by grunting-like sounds, nasal flaring, cyanosis, as well as retractions that can be intercostal or sternal. Sometimes edema, lethargic, and apnea occur as the condition worsens. Now, when you look at the hyaline membrane disease, what are you looking for? You're looking for respirations that increase to 60. You're looking for the grunting. You're looking for the nasal flaring. And you're looking for these signs and symptoms that we described. They may have periods of apnea, and we've talked about that. And they may have hypoxemia or hypercapnia, which is the elevated carbon dioxide. If those occur, that leads to respiratory acidosis. Now, what happens if a baby has acidosis? It causes vasoconstriction and damage to the epithelium of the lungs, which leads to the hyaline membrane formation inside the alveoli. Here is a description of what you are looking for when you see respiratory distress. The tachypnea, the respirations are greater than 60. The dyspnea, the grunting, the flaring of the nares, the cyanosis, the retractions. All that goes hand in hand with RDS. If a preterm delivery is anticipated, fetal lung maturity can be accelerated before delivery by the administration of corticosteroids. Remember that we can give the beclomethasone to the mother in divided doses to help increase or help develop the fetus's lungs. Now, if the fetus is born and a preterm infant, then we can give surfactant via the ET tube at birth, or if the infant has signs and symptoms of RDS. Surfactant can improve the neonate's lung function, and it's generally seen within 5 days of administration. So administering the surfactant after birth through the ET tube, you're not going to see an immediate result. You're only going to see it within about 5 days after the administration. So when you look at doing an amniocentesis, if it shows a low LS ratio, then that's when the corticosteroids are indicated. Now, our nursing care, what is our role as a nurse in monitoring the neonate during the management of RDS? So, for instance, if we're giving IV fluids, how are we going to observe for under administration or over administration or hydration of IV fluids? We're going to be looking at the core temperature. We're going to be looking at the weight. We're going to be looking at the mucosa, and the fontanelles are important, as is the heart rate. So we need to make sure we're monitoring vital signs, minimal handling of the infant to conserve the energy, and we want to make sure that we have a pulse oximetry and we're looking for oxygen toxicity. We talked about the antenatal corticosteroids as treatment. This is an infant that's probably going to the ICU, the NICU, the neonatal intensive care unit. They're going to need that surfactant therapy. They're going to need O2 therapy, and they may even need CPAP, or they may need mechanical ventilation support. If the baby's breathing 60 breaths or more, they've got retractions, they've got grunting, they've got nasal flaring, and if those respirations keep increasing, they're going to wear out eventually. They can't breathe like that for a long term, so they may need to rest, and they may need ventilatory support. They may need humidified high-flow oxygen through the nasal cannula, but they're going to have some respiratory support for the RDS. Transient tachypnea of the newborn. It's a common self-limiting condition of infants in which tachypnea increases oxygen needs. It's mild respiratory distress. They do have retractions, they have grunting, and they have mild cyanosis. But this commonly occurs in infants that are sedated from maternal pain medications. Maybe it's been a prolonged labor. Maybe this is a macrosomic infant. Maybe this baby's been born by C-section. So we need to provide nursing care, provide warmth. We need to conserve the infant's energy, and we need to provide supplemental oxygen. Now, transient tachypnea of the newborn can last anywhere from birth up to 72 hours, maybe even longer than that. But you usually can see a resolution. Babies will need a chest x-ray to interpret and decide, is it TTN or is it RDS? So a chest x-ray usually is ordered to help providers distinguish, is this transient, is it going to resolve and go away, or is it RDS and this infant's going to need longer care? So we want to make sure that we get that chest x-ray done if the provider orders it. Another cause of respiratory distress in the newborn can be meconium aspiration syndrome. The fetus may become stressed by placental insufficiency, cord compression, or infection. Anything that stresses the fetus in utero may cause the fetus to expel meconium into the amniotic fluid. Now remember that the fetus is swallowing during in utero. They're not swallowing constantly, but they're swallowing. They are practicing swallowing. So anytime meconium is expelled into the amniotic fluid, then newborns are going to swallow it. So you may see signs and symptoms of fetal distress by the external fetal monitoring or the internal fetal monitoring. You may see some cord compression or other conditions that causes this fetal circulation to be compromised. Asphyxia or acidosis can occur. So the fetus may only have gasping movements that causes the fluid to be drawn into the lungs. As the fetus struggles, they may swallow and draw fluid into the lungs. So then at delivery, it can occur if the baby has passed the meconium before birth, but maybe has not swallowed it yet, but maybe at birth, if they inhale that meconium in their nose and mouth before they've been suctioned, they may swallow it, they may aspirate it, it may go down to the lungs, and then they're going to have meconium aspiration syndrome. Now the meconium, remember, is thick and mucousy. It can block the infant's bronchioles, causing poor oxygenation. It can cause pneumonia. It can cause a pneumothorax. And this is mostly found in term and post-term newborns. So what are we going to do? Well, when the fluids rupture, whether it's spontaneous or artificial, if we see that the meconium stained fluids are there, then we're going to have everything prepared when that baby's born to hopefully when that head delivers, we can go ahead and suction that baby's mouth and nose before it takes its first breath. So a lot of times I have seen OBGYNs let the head deliver and suction the head before they even deliver the shoulders. They have long tubing and they have their suction catheter and they suction that baby's mouth and nose before they deliver the rest of the baby. And they try to get out as much as that as they can before the baby ever takes a breath. So what are some of your signs and symptoms? The greenish yellow staining of the skin, nail beds, and or umbilical cord. The tachypnea, they're going to be breathing fast. They're going to have the retractions, the nasal flaring, and the grunting. Their O2 sat's going to be decreased, and they're going to have decreased breath sounds. Now we said management is to try to suction before the first breath. But if we are unsuccessful, we may need to intubate and suction if possible. If they're having a lot of respiratory distress and they are getting really sick, they may need to be intubated and then they're going to go to the NICU. And they're going to need medical treatment. They're going to need a chest x-ray. They're going to need IV. They're going to be NPO. And they're going to need some O2 on board. They're going to need constant vital signs. But they're not going to stay in one of these area hospitals here. They're going to a higher level of care. So they're going to be transferred to a NICU. We want to make sure we prevent hypothermia We want to make sure we're watching our IV fluids so we don't underhydrate or overhydrate. They need the appropriate care to manage the meconium aspiration syndrome. Newborns that present with persistent pulmonary hypertension, it is as if the circulation did not change and they still have fetal circulation present and persisting as it was in the uterus. So the ductus arterius and or the foramen ovale remain open. They do not close as expected, and it causes pulmonary hypertension. Now, the blood is shunted away from the lungs. The lungs have high pressure, and there's inadequate blood flow to the lungs for oxygenation. Now, remember, when these babies are born, they are supposed to be ready-made, so to speak, to change that circulation immediately. But if it does not change and convert to adult circulation or normal circulation, then fetal circulation persists and it causes this baby to be sick. Now, some of the symptoms are similar to the RDS, but the cyanosis does not improve with oxygen administration. So this baby is another candidate that's going to the NICU. You're not going to hold on to this baby. You're going to stabilize this baby. And if you don't have a NICU in the hospital you're working at, they're going to be transferred to the NICU. You'll maintain and stabilize this baby until they get to a higher level of care. Now, some of the causes of persistent pulmonary hypertension is perinatal asphyxia, respiratory distress, neonatal sepsis, there may be infection somewhere, or they may have a congenital defect of the heart and or lungs. Now, they may have signs and symptoms of shock. They may have a very low blood pressure. This is a baby. Any of these sick babies are babies that you're going to need to get a blood pressure on. You want to know what this pressure is on this baby. They may experience tachycardia, heart rate above 160. They may have a heart murmur. You may hear that swooshing, that clicking, that thumping sound that's caused by that open ductus. So it could resolve, or the infant may have to have, so I have seen infants go to Atlanta with pulmonary hypertension and be put on ECMO if it didn't resolve. So they may have ongoing health problems. And they also have a higher risk of neurosensory hearing loss and neurodevelopmental problems later. Think about how much oxygen is required for this baby. And remember, the cyanosis is not going to improve, but we got to oxygenate the vital organs until it either is intervened or it resolves. So they're going to have oxygen, and it may be prolonged oxygen therapy. Cold stress in the newborn, whether it be preterm or full term or post-term. Cold stress is never good in an infant. We've talked about in the earlier chapters how to avoid cold stress, how to avoid hypothermia. It is the decreased skin temperature. It causes the respiratory rate to increase. The infant may have apnea. It causes bradycardia. It causes mottling of the skin, and the infant can become lethargic. Now, when we have the baby under the warmer, we want to make sure we are monitoring the temperature. We want to have a skin probe in place. The radiant warmer or closed isolette, we just don't need to put the baby there without monitoring the baby. And then we need to make sure that we're getting frequent vital signs, the temperature. We want to make sure all surfaces are warmed before we move or before we place the infant on there. You can look at table 17.3 in your book about infants with cold stress and see the identifying and the treatment, how to treat the cold stress in the newborn. You can see who is at risk, a preterm or post-term, a diabetic baby, an SGA baby, an LGA baby, And babies that are stressed at birth can have cold stress. Remember, babies don't shiver, so you have to know what the signs and symptoms are. Respiratory rate increases, and they may have apnea. Now, the probe placement is the right upper quadrant of the abdomen. We don't put the skin probe over bony prominences or in the line of cool oxygen or under a diaper. It needs to be visible to the radiant warmer. The ideal temperature is to warm between 97.2 and 98.6. Hypoglycemia in the newborn or the preterm infant is when the blood sugar is less than 30 in the first 24 hours of life, and then after that less than 40. Now between 30 and 40 we try to breastfeed or bottle feed the infant. A lot of times now when the baby is born, that's why they encourage breastfeeding immediately as soon as possible, so they can go ahead and get the food on board or the milk on board. Remember, those glycogen storages in the liver can be depleted quickly, so infants need to be fed if they're stable as soon as possible. Now remember that preterm infants have not remained in utero long enough to build up the glycogen storage and the fat. So remember, as the preterm works, they're using up that storage and they have an increased potential to be hypoglycemic. Now, hypoglycemia can occur with any condition that increases metabolism, which increases the glucose needs. The energy requirements place more stress on the already deficit stores. Then you have these signs and symptoms: tremors, the weak cry, they become lethargic, and they may have convulsions if the blood sugar is low enough. And I have seen infants that we do a blood sugar and get a 9, and we're like scrambling trying to get this baby situated before it does start having convulsions or serious side effects from the hypoglycemia. So now remember that a newborn's glucose can drop if there's no glycogen stored in the liver. It's used up the glucose for heat production or birth stress. If the mother is insulin dependent diabetic, and if it has hyperinsulinism, which is increased insulin levels. And maybe it's a poor feeder, it cannot feed enough to keep the glucose level in an acceptable range. If you run into a problem with an infant that cannot maintain the glucose, they're going to need an IV, and they're going to need some D10 to give them that dextrose they need. Once we get a low glucose and we provide a feeding, we want to recheck that feeding 20 minutes after. If the glucometer is less than 30, then usually the hospital has a protocol in place, and of course we want to notify the healthcare provider. Now, low levels of glucose lead to brain damage if it's not treated. Long-term complications from frequent or prolonged hypoglycemia are the neurological damages, such as intellectual disability, developmental delays, personality disorders, decreased head size, and then we said convulsions or seizures. So most of the time the blood sugar on an infant or a newborn is a heel stick. We stick the bottom of the heel, and we check it usually after birth. For any large or small birth weight newborn, most of the time your hospital protocols have protocols set in place. So if the baby is born of a diabetic mother, maybe chronic hypertension, maybe an SGA, an LGA, different criteria that meets that baby causes that blood sugar to be drawn. So remember that mark is 30, and then after that it needs to be above 40. Brachial plexus injuries with newborn birth injuries. It occurs when the increase in the infant's neck or shoulder angle resulting is the traction force to the brachial plexus that controls the movement in the sensation of the shoulders, the arms, and the hands. Now remember the positioning of the fetus. Sometimes if it's not completely flexed or positioned like it should, maybe they've got one shoulder out and can't get the other shoulder out, so it can cause brachial plexus. Now there's going to be decreased range of motion on one side of the body. The Moro reflex is going to be affected on that side. They may have a claw-like appearance of the hand on the affected side, and they may have abnormal muscle contractions on the affected side. These are babies that are born that when you check the tone in both extremities, upper extremities, that one affected extremity is going to be kind of flaccid and it's not going to flex like the other extremity. So if we notice that as a nurse, if we notice that the arm does not have the same tone and is flaccid, we need to report it to the provider. We need to protect that affected arm from dangling when held or moved. We don't want to lift the infant under the axilla. We want to look for pain and report to the provider. And we want to try to position the infant with good body alignment. This baby may need physical therapy, range of motion activities, and sometimes surgical intervention is needed to provide a nerve graft. Now we as nurses need to educate the parents on how to support the affected arm, as example of a rolled blanket when the infant's in the car seat or in the crib. So we need to educate the parents on brachial plexus. Hyperbilirubinemia, or jaundice, is when the immature liver contributes to a condition called icterus. Now, the icterus is jaundice of a newborn due to the immature liver. It's unable to clear the blood of the bile pigments that result from the normal postnatal destruction of red blood cells. Remember, we said that the red blood cells are higher because of the labor stress and they're destroyed. And sometimes if there's rapid destroyment, then it causes jaundice. But if the icterus is in place, it begins to cause jaundice as well. Now, when the bilirubin begins to deposit in the brain, it can cause the kernicterus and cause the neurotoxicity. We always want to make sure we're watching the levels and we're intervening in an appropriate manner so that this does not happen. We don't want the bili to get too high. Now, infants have that yellow-orange cast in the white of their eyes and the mucous membranes, and then their skin turns yellow. And we said earlier slide, I think it was 5.3, this says greater than 5 in 24 hours, or a bilirubin above 12.9 requires careful investigation. Remember, the ABO compatibility can occur. We make sure there's certain blood types from the mother that we get certain blood types from the baby. O positive and B positive are the two that we always get the baby's blood type. We always check the DAT, and then we watch closer for jaundice as well. Breastfed infants can show jaundice at about 4 days after birth, and then they peak about 3 to 5 days after birth, about 72 hours after birth. So remember that the key to maintaining jaundice is to know the signs and symptoms to look for, the yellowing of the sclera, the mucous membranes at the cast of the skin, and it goes in a head-to-toe position. You normally see jaundice on the head first, the facial features, then you'll notice it on the trunk, and then you'll notice it covering the whole baby's body. We want to monitor. Remember, we said we do a transcutaneous bili at 24 hours. That's the skin. It's not invasive. It's just a skin measurement. And then we want to make sure we're feeding every 2 to 3 hours because bili is excreted in the stool and the urine. And then if they need phototherapy, we want to make sure that we're following the parameters for the phototherapy. Now remember, the phototherapy is an intervention for jaundice, and the bili lights breaks down the bili in the newborn or preterm's body. We said the yellow color spreads down the body. We want to breastfeed or bottle feed, increase the feedings if we can, monitor the I&O, and use the phototherapy, and we said that, and these are your levels here. Laboratory testing, if you do the transcutaneous Billy and it's greater than 5 or 5.3, then you want to get a serum. That's usually a heel stick as well, and they get a definitive number so you can decide what kind of medical management the infant needs. Remember, phototherapy breaks down the Billy. We need to make sure that we are covering the eyes because it can harm the eyes. We want to make sure that all the skin is exposed with the exception of the diaper area that needs to be closed most of the time. We want to make sure that the baby is warm when it's under phototherapy. And we want to make sure that we're monitoring the I's and O's on the infant. And I believe that is on the next slide as well. Here is some of the things that I've already said. The hypothermia, the I's and O's, increase the feedings, eye patches to protect the newborn's eyes, maximum amount of skin to the light except for the genital area, and we want to make sure we monitor the newborn's behavior. The goal with jaundice, physiological jaundice and pathological jaundice is different, but the goal is to prevent the kernicterus, the neurological complications, by preventing the rising bilirubin levels in blood so it doesn't stain the basal nuclei of the brain. We need to observe the skin, sclera, and mucous membranes. Progression of jaundice needs to be reported. The lab values need to be reported if they continue to rise and not decrease. And we want to see how the infant's responding to the phototherapy. So we know that the kernicterus causes brain damage, also known as bilirubin encephalopathy. So we want to make sure that we're monitoring that infant closely when we're treating jaundice. Sepsis in a newborn is infection in the blood that presents within their first 28 days of life. GBS is a contributing factor, E. coli or herpes. They may have a low temperature, they may have poor feeding, they'd be lethargic, irritable, and respiratory distress. We need to make sure we're giving IV antibiotics, provide warmth, make sure the baby's feeding well, vital signs. We want to help the infant conserve energy as much as possible and use strict hand hygiene. Now, chemicals released into the blood help fight the infection and cause inflammation over the entire body of a newborn. So remember that the newborn's immature immune system is unable to fight against severe infection before it becomes systemic. So we have to watch. A lot of times the baby doesn't, you can't really tell that the baby has an infection. So these signs and symptoms that we included in this slide are very important, especially if it's a consistent low temperature, if your baby continues to poor feed, if your baby continues to be listless or non-active, and then if respiratory distress occurs. It is always a good thing to get a CBC and a blood culture to rule out any kind of infection. Here's some of your terminology with your newborns, what defines preterm, early term, full term, late term, post-term. Gestational age is always determined on a baby. There's a Ballard score, and we've talked about that. That's standardized. Every baby should get a Ballard score to determine a level of maturation, how well the baby is developed at birth. And also it gives us a clue of how the organs are going to function outside of the uterus by physical exam, observation of behavior, and then family history. Your SGA, or small for gestational age, could be contributed to intrauterine growth restriction of the newborn, or IUGR. This is limited fetal growth caused by the decrease in the placental perfusion during not digestion, during gestational age. So when we look at the baby, we look at the weight and the length and the head circumference to see how symmetrical they are and where they fall on the graph. If they all fall below the 10th percentile, we measure them as SGA. Now, some SGA babies have a large head in relationship to the rest of the body. Their extremities and trunk are thin. They have loose cord and they have a thin umbilical cord. A lot of times SGA is diagnosed during pregnancy when the baby is still in utero, when they get routine measurements at their routine appointments, or they measure the fundal height and they determine that this baby is not growing appropriately and they are suspicious that this baby might be an SGA baby at birth. Some of the risks that occur with an SGA infant is asphyxia during labor, if the SGA was due to placental insufficiency, meconium aspiration, hypoglycemia, and hypothermia. So these are some of the risks that occur if this infant is SGA. Now, we as a nurse need to make sure we get that gestational age assessment done. We need to look for respiratory distress. We need to observe for hypoglycemia. These infants are very subject to have a low blood sugar. We want to make sure that we are feeding appropriately to prevent the hypoglycemia. We want to make sure we monitor the temperature and the daily weight. We want to teach parents to keep the infant warm and to provide frequent feedings. This is an infant that might need a slow flow nipple if the suck and swallow is not coordinated yet, because we want to make sure they're feeding as well as they can for their size and for their condition. Just as you can have an SGA baby, you can have an LGA baby, large for gestational age. This occurs in babies that can be post-term, it can be diabetic babies, or it can be idiopathic, which means this baby may just be a LGA baby. So it's a large obese baby. It can be listless, it can be apathetic. So we want to make sure, again, we're doing the gestational age. We want to look for respiratory status because sometimes LGA babies do not perform well respiratory-wise. We want to look for birth injuries like that brachial plexus. They might have a broken clavicle. I did hear of somebody say just recently that there was a baby born that was LGA and the shoulder and the arm was broke to get that baby delivered. So sometimes birth injuries occur with the delivery of an LGA baby. Tremors provide frequent feedings as well. We want to make sure that this baby is monitored closely. This is a baby that's going to be more than 4,000 grams and that is going to fall in the greater than the 90th percentile when we measure this baby out. Most of the time it's caused by diabetes, but as we said, it could be post-term and it could be idiopathic. We talked about fracture of the clavicle and the arms. They may have asphyxia, they may have a brachial plexus. If they may have meconium aspiration, respiratory distress, and hypoglycemia. We talked about preterm infants at the very beginning of this lecture, but these are some complications that can occur with preterm infants. The necrotizing enterocolitis, the guts, I always say the gut's not ready to have food pass through it, and it can die, and it can get infected, and it can cause the bowel to perforate. So it's the abnormal intestinal flora, it's immaturity of the intestines, and ischemia or a genetic predisposition. So vomiting with the feedings, diarrhea, delayed gastric emptying, decreased bowel sounds, the infant may be lethargic, they may have abdominal swelling, so we need to measure the abdominal girth, and you might see those visible intestinal loops in the abdomen. I've seen a couple of these, not very many. I've not had a lot in my practice or my nursing career, but I have seen necrotizing enterocolitis, and I have seen infants go to a higher level of care and have some of the bowel removed because it was necrotic by the time they got to it. So it can happen. They have to be NPO, they have to have an NG tube, they have to be have IV and IV antibiotics, and surgical intervention is necessary. That's why it's important to measure the abdomen as well, even though it's not one of the routine measurements. They mainly focus on the length, head, and chest, but I've always measured the abdomen so I have a baseline on what that abdomen was at birth. Hematoschisia can be bright red blood in the stools in a newborn, and remember, a lot of times these infants are a candidate for surgery to get that corrected. The post-term newborn is defined as infants born after 42 weeks gestation. The reason can be unknown. In some cases, the placenta begins to detach and break down, leads to placental insufficiency. Sometimes nutrition and oxygen is lacking. An SGA infant must be watched closely if this has occurred. But remember, the placenta, just like the baby is only supposed to be in utero for so long, the placenta is also supposed to be attached for so long. So after a certain point, it does not function well, and it can cause fetal distress if labor has not ensued. So what are some of the characteristics of a post-term newborn? They're more alert. They have decreased subcutaneous fat. They might have loose skin. The skin is dry, peeling. They look really mature. They have long fingernails and toenails. The ear cartilage is more than a soft and firm recoil. It's more of a stiff. And they may have passed meconium if they're after 42 weeks gestation. So this cord may be stained. It can cause a stillbirth or neonatal death. It can cause a difficult labor due to the larger body size. Post-terms are more potential to be hypoglycemic. And as we said, if they pass meconium, they may have meconium aspiration syndrome. So we need to observe these infants for respiratory distress or meconium aspiration syndrome. We need to observe them for hypoglycemia. These babies are going to need to be monitored closer with their blood sugars. They might have polycythemia, which was going to cause hyperbilirubinemia. And the fat stores may be depleted in utero because they're post-term, and they may have cold stress. This is an infant that, even though it looks healthy, acts healthy, appears healthy, it may have cold stress and need to be placed in an incubator. They may be long and thin, and they could have had the potential to lose weight because they are post-term as well. It's very rare now that you see a post-term baby after 42 weeks. Most providers, due to the risk involved, will not allow a patient to go past 42 weeks. They really encourage them to be delivered by probably 41.4 or 5 before they get to that 42-week mark. They really like for them to be delivered. You do see it on occasion, but it is rare. So let's look at this question for review. What are the differences in the appearance of a preterm infant and a post-term infant? So we know that a preterm is less than 37 weeks. The skin is transparent and loose. We see the superficial veins, the abundance of lanugo, the vernix is present. They don't have as much subcutaneous fat. They have inadequate respiratory function. They may have periods of apnea. They might have hypothermia because their thermoregulator is not ready to be controlled yet. They have a higher risk for hypoglycemia, hypocalcemia. They may bleed easier if they have a lot of oxygen on board. They might have retinopathy, a prematurity. They may not feed well. They may have necrotizing enterocolitis, and they may have jaundice. So infants that are born to diabetic mothers, the neonatal complications are directly related to the inadequate glucose control in pregnancy. A lot of times diabetic mothers do not control their glucoses, so it can make a sick baby or cause the baby to have hypoglycemia. Congenital malformations can occur. High blood sugar concentrations are toxic to cell growth in the first trimester. So think about the uncontrolled glucose. The fetus is forming and developing. That blood sugar is so high that it becomes toxic to that cell growth or cell development in the first trimester. It can cause cardiac and central nervous system abnormalities of the fetus. Remember, all that's occurring in the first few weeks of pregnancy. So if we see a congenital abnormality, if it's obvious, we want to make sure that we are taking care of it appropriately. If there's any physical abnormalities or abnormal vital signs, we need to let the physician know. Cardiac, the ductus may not close. It could be a heart defect, so we need to make sure we're listening to the heart correctly. Cardiomegaly could be in 30%. Spina bifida can occur, and that's when the spinal cord fails to develop or close properly in the uterus. Remember, we want to look for that tuft of hair and that pinpoint in the sacrum to see, make sure that there's not a dimple there, and if there is a dimple, it is a closed dimple. Most of the infants that are born to diabetic mothers are macrosomic or large. They weigh more than 4,000 grams at birth if they're full term. You can get a full term 4,000 gram baby that's come from a diabetic mother that's going to be sick, and then you can get a 36 weeker that's still going to be LGA that's going to be sick when it's born too. So the high levels of maternal glucose lead to fetal hyperglycemia and hyperinsulinemia, which is excess insulin, which causes the increased growth in the fetus. Now, we talked about shoulder dystocia if it's a vaginal birth with an LGA baby. And then they look ruddy, they look fat, they look puffy, and they don't always have good muscle tone. So we need to let the provider know. Remember, nurses are usually the first ones that come in contact with these babies. So we need to let the provider know the birth weight and signs of macrosomia, the gestational age, the battle needs to be done, birth injuries if they occur, and then hypoglycemia. Remember that it occurs in 15 to 45% of diabetic pregnancies, and the macrosomic IDM is typically delivered C-section. If they know it's going to be a large baby, they'll usually have a planned C-section, and then we need to observe for signs of hypoglycemia in the infant. They're normally going to have a stable blood sugar at birth, but it's going to drop pretty rapidly after birth because the insulin from the mother is gone. They develop the hypoglycemia, as I said, due to the rapid fall of the glucose. And then when the cord is cut, the glucose influx is over. The fetus is left with high levels of circulating insulin, which leads to the hypoglycemia. Now, so these are infants that we have to watch just as closely as we would watch any other infant. We don't want this infant to get cold and use up the glucose storage that it has. We don't want to respiratory distress because that's going to use it up even more. And then we got to watch for fetal hypoxia because poorly controlled maternal diabetes leads to a decreased supply of oxygen to the fetal tissues, and it decreases oxygen blood flow to the placenta. So chronic fetal hypoxia can lead to intrauterine death or to respiratory depression at birth. The fetus attempts to compensate for the decreased oxygen. It produces extra blood cells during that case and causes it to have polycythemia. The polycythemia is when the hematocrit is greater than 65%. It increases the risk of stroke, seizures, and hyperbilirubinemia. So when you look at this baby, you're going to see ruddy red skin. You might see sluggish capillary refill time. You may see respiratory distress. They may have episodes of apnea. They might have some cyanosis. They might have poor feeding. They may be lethargic. Seizures can occur, and they may have hematuria. So we want to let the provider know if we observe any of these signs and symptoms. We want to give IV fluids and observe closely for signs of fluid overload. Now, when we have polycythemia, we want to make sure that we're monitoring the vital signs. We want to make sure that we're monitoring the hematocrit and the blood glucose. Some physicians will do a partial blood exchange transfusion with saline to decrease the hematocrit quickly in symptomatic infants. Now, asymptomatic infants are just observed for any symptoms that can occur, and they'll let the body adjust to the hematocrit and let it compensate naturally. Most of the time, physicians will hydrate the infant with IV fluids. Some infants of a diabetic mother might be hypocalcemic or hypomagnesia. So that's their calcium is less than 8 or their magnesium is less than 1.7. This can occur in the infants of a diabetic mother. So the poor control of the maternal glucose makes the glycosuria, which is accompanied by magnesium loss and loss of calcium. If you lose magnesium, you're going to lose calcium too. So they may have poor feedings, they may be lethargic, there may be tremors, seizures, they may have irregular heartbeat, and they may have respiratory distress. So as we observe these signs and symptoms, we need to let the provider know, continue to monitor closely, give the calcium and magnesium if it's ordered, and educate and support the family.